Alrighty, so if you want to understand an ECG, you need to first understand this. And when I say this, I mean the electrical conductivity of the heart. So this is the right-hand side, and this is the left-hand side. Patient's left, patient's right. So these are your atria, and these are your ventricles. So your atria contract first, and the way these contract is that there's a little node here called your sinoatrial node, or your SA node. That fires first, and it causes contraction all over your atria, so that your atria prime blood into your ventricles. Then this travels down into another node called your AV node. AV, atrial ventricular node, between the atria and the ventricular. Great name. And then it travels down your septum of the heart and up the ventricles. These are your left bundle and your right bundle. So you might be like, well, why is this important? Well, to understand an ECG, you need to understand what you're looking at here. So there's a guy called Beethoven, and he made a triangle. Probably heard of it. It goes something like this. All right, so Beethoven made Beethoven's triangle. And what he worked out is that depending on which side of the heart we're looking at, we can tell what we're reading. But what's important to understand is that in his triangle, each side is from negative to positive, or you see here it's two negatives and two positives, and negative and positive. So it depends which way you're looking at the heart, but these are all different views of the heart. So the most common view we have is lead 2. That's the lead that we monitor on because it's the lead that we're most familiar with. So you need to imagine that when you're looking at lead 2, you're looking at the heart from this angle, all right? When you're looking at the heart from this angle and you see current move from left to right, so from negative to positive, we see a positive flexion. If we see a current move from positive to negative, we see a negative deflection. If it moves towards or directly away, it is a kind of the same thing. Goes up and down equally and then just returns back to normal. So if you have a look here, the first thing we see here is the SA node firing, and it moves from left to right. So we see a little wave, all right? Kind of starting to draw an ECG of what we would see if we were watching from lead 2. Then we see the AV fire, but there's that pause. So we see a bit of a flat line. And then we see this big contraction of the right and left ventricles, knowing that the left ventricle is bigger than the right ventricle. So this view kind of sums up all the conduction and summarizes it into whatever is biggest or the most conduction, which is this movement. So there's this massive up, all right? So that's that because it's going from negative to positive. And then we see this curving around the heart, which then gives us a S wave. So the heart then repolarizes and it gets ready for another contraction. And what that does is that then that looks like another wave, but much smaller. And we have the T wave. So we have your P wave, QRS, and your T. In the next ECG, we will be talking about that more. So let's move on to our first ECG. All right, so this is an ECG. So let's put some labels on here. All right, so the first little positive wave we see is a P wave. Then from there to there is called your QRS, and there's your T wave. So remember, the P wave is the sinoatrial node firing, the QRS are the ventricles firing, and the T wave is the repolarization of the ventricles. So how do we assess an ECG? All right, so the first thing you want to ask yourself is how fast is the rhythm, and is it regular? So how do you assess how fast the rhythm is? Well, you can count the big blocks in between, all right? But you might be like, but James, what is a big block? What does that mean? So you'll see that there's lots of big blocks, and then inside every big block there is a small block. So every tiny little block, and there's 5 of them in each big block, is 0.04 seconds. Which means that every big block is equal to 0.20 seconds, because there's 5 tiny blocks in every big block. So that means that if we count every big block in between every R wave, so remember that the top wave is your R wave, this little wave here is your Q, so it's QRS. So between every R wave, you can count the big blocks, and you can divide the number of blocks you have found by 300. So we go, well, that's 1, 2, 3, 4. So 300 divided by 4 is 75. So we have a rate of 75. Now you're going to ask, is it regular? Well, there's only one way to work out if something is regular. You take a piece of paper, you find your R waves, and you put a little dot there and a little dot there, and you shift it across. And if the R waves are on point, so obviously no more here, but if your R waves are on point, that is a regular rhythm. So we have a regular rhythm running at 75. So normal heart rate is 60 to 100, so that is a normal rate. So now let's actually look at the ECG. So questions you want to ask yourself is there a P wave before every QRS, and is there a QRS after every P wave? So P wave, QRS, QRSP, P, QRS, QRSP. Yeah, so it's normal, all right? So you want to try to find things that are abnormal. So from the start of the P to the start of the Q is your PQ interval, and that mustn't be more than 5 tiny little blocks. Your QRS, starting from your Q and ending at your S, can't be more than 3 tiny blocks, so 0.12 seconds. And the T wave, the center of the T wave, mustn't be more than half the way between your R and R. So halfway between here, probably about there. So your T wave is normal. Your T wave is also not very big or spiked or anything like that, which can obviously mean other things, but here we have a normal size, normal shape, and that's really what we want. So because we have a P wave, it means that it is a sinus rhythm, because it's coming from the sinoatrial node. So this is called a normal sinus rhythm. Normal sinus rhythm. Cool, so that is the first and most basic ECG. Let's move on to the next. Our first question is rate and rhythm. So there's 2 big blocks between your R and R. So 300 divided by 2 is 150. So it's fast, faster than normal. Is it regular? All right, so if we take 2 dots like that, we shift it, we shift it, shift it, shift it. So cool, we have a regular rhythm. So we have a fast regular rhythm. P waves before every QRS, QRS before every P. It looks like it. So that's where your P starts, and that's where the T is. So P and T in your QRS, just to help you guys see. So the next thing we're wanting to ask ourselves is the P wave normal, and is the PQ interval normal? So less than 5 little blocks, yeah, sitting at 4. QRS is less than 3, yes it is. The T wave, is it halfway between here? No, it is not. So our T wave is normal, it's also not very big. If it's more than halfway bigger than your R wave, it's considered big. It's always in proportion to the other waves. It's never like, well, it's 5 blocks high, so it's big. It's always in proportion to the other waves, generally the QRS wave. So we have a P wave, meaning it's coming from the sinus or the sinoatrial node. So it is a fast sinus rhythm, so we have a sinus tachycardia. Nothing else really to talk about. This rhythm looks quite slow. Let's count how many big blocks there are to work out a rate. So we have 1, 2, 3, 4, 5, 6, 7. 300 divided by 7 is 42. So normal is 60 to 100, so this is a slow rhythm. P wave before every QRS, QRS before every P. P, QRS, The P wave is less than 5 blocks. The QRS is less than 3 blocks. The T wave is not past the midway, and it is not more than half the size of your R wave. So normal, normal, normal. So because we have a P wave, it means it's coming from the sinoatrial node. It's a slow rhythm coming from the sinus node, so it's a sinus bradycardia. That's about it. All right, that looks like a kid might have drawn it. There's no pattern, there's no rhythm. So I can't really work out what is what here. You can't see P waves or T waves or Q waves or anything like that. But what I can see is that there is a very broad stroke. So that is your ventricle doing something. It's bigger than 3 little tiny blocks, so it's broad. And if your QRS is bigger than 3 little blocks, it is most likely a ventricular rhythm. I can't see any P waves, there's no pattern. So this is a ventricular rhythm, and it is a fibrillating. So this is what a ventricular fibrillation looks like. So you can see how it's broad and how there's no pattern. There's no rhythm, it's not regular in any way. It's changing in sizes all the time. So the way you treat this is you defibrillate. So we have a ventricular fibrillation. Treatment is defibrillation. That's pretty much all I can say about this. The reason why it looks like this is that each cell in the heart can depolarize by itself. So each cell in the heart can actually contract by itself. And what that means is that when the heart becomes hypoxic or is damaged by trauma or whatever it is, all the cells in the heart can contract whenever it wants. And when that happens, you have chaos. And that is exactly what chaos looks like. Next rhythm. Let's work out rate. Well, there's nothing really to count because there's nothing on the rhythm. So we can't see P waves, QRS, nothing. But if you notice, it's not perfectly flat. So what you want to do is you want to increase your gain. Gain on a monitor allows you to make the rhythm look bigger, so we can look at it closer. And you'll notice that it's not perfectly flat. So this is called asystole, and it means that the patient's heart has got no conductivity. So the heart is dead. These patients have no pulse, they are not breathing, and their heart is completely dead because there is absolutely nothing. But notice, it's important that it's not perfectly flat. If you have a perfectly flat line, your monitor is probably not plugged in. Alrighty, so let's work out rate. There's 2 big blocks in between, so 300 divided by 2 is 150. So it's fast. Is it regular? Rate is regular and it's fast. So this might look really confusing, but what really is happening here is that this is your T wave. This is your Q, R, and S. So you'll notice that there is no P wave, which means it's not coming from the sinoatrial node. How broad is our QRS? Well, it's much bigger than 3 little tiny blocks. So it's a broad QRS, meaning it's coming from your ventricles. There's no P wave, so it's definitely not coming from the SA node. So this is a fast rate coming from your ventricles. It's called a ventricular tachycardia, VT. These rhythms can have a pulse or not have a pulse. If you ever see this, it is a ventricular tachycardia and you need to assess if there's a pulse. If there's no pulse and no breathing, you need to defibrillate. If there is a pulse, then you don't just quite defibrillate, but if they are unstable, meaning that the patient is in shock, you can cardiovert. That's another topic for another day. But if a patient has this and there's no pulse and no breathing, you're also going to defibrillate that. All right, so let's look at the next ECG. Remember, first thing we want to do is rate. How fast is it? So 1, 2, 3, 4, 5, 300 divided by 5 is 60. Okay, next question is it regular? So take a piece of paper, take some knots. We have a regular rate. Fantastic. So it is running at 60, which is normal, and it is regular. All right, so do we have P waves before every QRS, and do we have QRSs after every P wave? So P, QRS, QRSP, P, QRS, QRSP, P, QRS, QRSP. So it looks like it's pretty consistent, but I don't know if you noticed how far away that P wave is. So the PQ interval, that's clearly more than 5 little tiny blocks. But there is definitely a P wave. So this means that we have a rhythm coming from the sinoatrial node, but it has a really long PQ interval. So the other thing to note is that the QRS is also a normal duration, so less than 3 little tiny blocks. So it's definitely not a ventricular rhythm or anything wrong with the ventricles, and there's definitely a P wave. So it's definitely a sinoatrial rhythm coming from the sinus node. However, the PQ interval is very long, and so this is what we call a first degree heart block. All it is that the PQ interval is broadened. It's also important to note that this can be normal in very fit individuals, like athletes or runners. So this is the next ECG. I can see that it is irregular because it's a small gap there and a big gap there. So you need to count for 60 seconds, and that's your rate, or you can count for 30 seconds, but you can't do the little rule of big blocks and 300 divided by number of big blocks in between. So what can we see in this rhythm? Well, the questions you want to ask is there a P wave before every QRS? So P, QRS, QRSP, P, no QRS. P, QRS. So there's P and QRS, P and QRS, P. And then it goes back. There's something missing here. There is a QRS that is just absent. Strange. But if you notice, the PQ interval is normal. It's less than 5 tiny little blocks. The QRS is less than 3 little blocks, and that is consistent. The P and Q interval is normal. PQ interval is normal. QRS is normal. Your T waves are not more than half the size of your R wave, so that's all normal, except that suddenly there is a P wave, and it just drops. So this is what we call a type 2 secondary heart block. I can once again see that it is irregular, so we can't use the 300 divided by the big blocks. You need to count for 30 seconds or count for a minute to get a heart rate. Is it regular? Well, we can't tell either. So what are we trying to work out? Well, let's look at our PQ correlations and our QRS and P correlations, all that sort of thing. So P, QRS, QRSP, P, QRS. There's a P and there's a QRS and there's a P and then there's nothing. So there should be a QRS here, but there isn't. But you might say, well, that looks very similar to the last ECG we saw, which was a type 2 second degree. However, you'll notice here that your PQ interval is normal, less than 5 little blocks. Here's your PQ interval is broadened. It's much bigger. All right, and then you see here P, and then it continues on. Look how long that is. It's probably about 6 or 8 blocks. And then you have a P, and then there's no QRS. So what's happening here is you have normal, broadening, broadening, drop. This is called a type 1 second degree heart block, or a Wenckebach. So kind of like what happens is that your PQ interval increases and then drops, and it's the only ECG that does that, where you have a increasing PQ interval and then it drops a QRS and then starts again and drops. So that is quite a clear indicator, and that's also why it's important to assess if you have P waves before every QRS and QRS after every P wave, as well as like your PQ interval, your QRS intervals, and all that sort of thing. That looks very slow. Once again, we can't tell rate or rhythm because we don't have enough ECG here, but you'd have to count the patient's pulse for 30 seconds and times 2, or count for 60 seconds to get an accurate rhythm, especially if it's slow. So we have a P wave, we have a QRS that's clearly very broad. It can't be more than 3 little blocks, and it's 1, 2, 3, 4, 5, it's almost 10 little blocks. So it's probably a ventricular rhythm. However, we have P waves, so the sinoatrial node is doing something, but I also don't see any T waves. So it's probably lost within that somewhere. So we have a P wave, QRS, P, P, QRS, P. So we have a P wave and a QRS and a P. Then we have a P wave with no QRS, P wave with, I guess, QRS, and then P wave. So what is actually happening here is disassociation between the P waves and the QRS. So you might be like, well, what's that? Well, what's happening is that the P waves are firing independently to the ventricles. So there's no correlation between the two. And the most important factor you need to consider here is that your P waves must be regular. Because if these P waves were irregular, it might be a type 1 or a type 2 secondary heart block. All right. So if we take a piece of paper, remember, regular, we go there, P wave, P wave, P wave, P wave, P wave. Oh, there's no P wave there, but if you look closely, there is a little P wave there. If you go there, P wave, P wave. So our P waves are firing at a regular rhythm. If we had enough QRSs on the ECG, we could also assess, and you'll find that your RR interval is also the same. So what's happening is that the P waves are firing, the QRSs are firing, and they're both regular, however, they're not together. This just happens to land before the QRS, but you see P wave, P wave, P wave, P wave. And it wouldn't be normal for a P wave to land inside a QRS, but that's what's happening there. So this is a 3rd degree heart block. Hope you guys enjoyed. If you want to see more of this, like, comment, subscribe, and we'll see what we can do.